Jyoti Dev set the context for use of GLP-1. Then Dr. Naidu came up and told us that peptides are here to stay. Everything in life is protein. We are sarcopenic Indians. We don't have too much of protein, and therefore, peptides are here to stay. But traditionally, when we thought of injectable peptides like insulin or conventional GLP-1 agents, we always thought of an rDNA technology or biotechnology. And then you needed, either a E. coli in a bioincubator hub or a Saccharomyces cerevisiae in a bioincubator. And Dr. Naidu very nicely said that we don't need all that now. In fact, Lilly was the one who started SPSS, LPSS techniques. And first, my congratulations to the team from Dr. Reddy's lab, because I think we should be proud as Indians. We are in their headquarters here. And Rakesh is a very integral part of this place. I know HICC because of him and his team. And clearly we recognize that it is not easy to make these peptides now. And this is the era of MABs. When the millennial 2000 was born, people who were born were called millennials. Then there came Gen Zs. New terms come in. I can see Sanjay Reddy is also here, Secretary of Diabetes India. But now this generation which will be born will be called a GLP-1 generation. So very clearly we know this. So that's something which we recognize. And also what is unique to know that though Novo makes, and I also speak for Novo, so I have a difficult proposition. My friend Madhavan fussed me here with Bansi, and I didn't have a choice to say no to either of them. Okay, so I'm speaking today for semaglutide, and on day after tomorrow I'm speaking for semaglutide for Novo. So kindly pardon me for what I'm saying. But one thing is clear cut. Eli Lilly makes that tirzepatide through a synthetic route. So it really doesn't matter whether you make it through a peptide or that, and some advantages Dr. Naidu very nicely said. But my job is very different. It is right patient, right therapy, who will benefit from the treatment. And I think Rakesh already did. This is talk for which all of us are paid, except probably people who work with Dr. Reddy. So it's Dr. Reddy and my team. I really have gratitude for Diabetes India, Bansi, Arvind, Sanjay, Amit Gupta was here some time back, and all of them. So very clearly we recognize one point, and I can see Dr. Bansi has just come, and today is 12th of February. So today day is special for Bansi because it is his wife Anu's birthday. So happy birthday to Anu. And so obesity doesn't travel alone, and it's a mother of all diseases. Whether it's mental health, mechanical health, and very clearly we recognize that. But the problem is that when you have 8 billion people on earth, of which 1.47 billion people live in India, which means almost 1/6 or 1/5 of the world lives in India. Affordability is a big gap. So 1 out of 4 people on the world have a weight issue. People have a lot of NCDs as an issue, but cost becomes a big problem in adherence. So clearly there is, even if I prescribe a drug, people have 2 issues. One is they can't afford it because it's unaffordable. Second is, of course, there is still some injection phobia. Indian doctors know this very well. People may say that there's no inertia for injections, but we are not anal about it. Many people will say you do everything but avoid the injection. So that is very clearly there. So non-adherence may cost comes up. People forget to take medicine. In fact, these are all silent diseases. We are treating numbers with sugar, numbers with blood pressure. NCDs are all silent. And therefore, minute the numbers become normal, people stop their medications. Also, people don't understand that we are here. These are disease modifying drugs, because we want, this to be complication free. And I remember in Diabetes India, Bansi taking us with Arvind to a then president of India, and trying to have a complication free world of diabetes. And the feeling of, and most people, minute they think that they have lost weight or they have their sugars are normal, they feel that they have conquered the world, and then of course sometimes medicines are not available. In fact, 5 years back after COVID, when the semaglutides and the tirzepatides were popular, half the time they were not available because they could not scale up the production, and that's a big challenge which we have. So I think the first point is that adherence is a huge challenge in healthcare delivery. And affordability is a rate limiting step for quality care. So I made my own slides, though my friend Arjun and Simran wanted me to talk on their slides. I made my own charana in it because I can't talk what you all tell me to talk. I will still tweak it, but I have not changed the base slides. Okay. And the top point is their point that 100% effective day drug has 0% efficacy if patients stop taking it. So clearly, I think that gap we have to congratulate all Indian manufacturers, but Dr. Reddy in particular because they are innovator. It's just not 5 years of research. I think those peptide scientists in the R&D lab, right from their founder, late Dr. Anji Reddy, have been constantly innovating novel peptides. So that old peptide platform, and you have the SPSS platform, and Lilly is a hybrid platform, which is SPSS and LPSS both. So obviously you are one step ahead of Eli Lilly also in that way. If you look at from a pure chemistry point of view, if you talk to Dr. M.M. Sharma, who is the big scientist in pharmaceuticals from UDCT, who founded UDCT, ICT, who taught Mukesh Ambani, they are all chemists. If you talk to them, they will tell you that when you make peptides synthetically, if you make it in hybrid, you still may have some impurities. But I think Reddy has gone one step ahead of that. So I think I congratulate your team. Put your hands together for all of them. I think this is very, very unique. And that's something which we need to recognize. So GLP-1 peptides can change the paradigm, and we have gone from a downstream approach to an upstream approach. We want to go beyond a glucose control approach to a weight first approach. And therefore, the primary lever for diabetes management is basically weight loss. And if you hit it early, not only the MACE will come down for a large pool of patients, and they can then afford if the treatment is affordable and accessible. So I think all of us will echo, Rakesh will echo, Bansi will echo, Sanjay, Arvind, all of us will echo that clearly affordability is a challenge. And therefore, if you want to have better persistence, better adherence, fewer patients to skip doses, and have better long-term outcomes, it is there. Oral is still popular. Whether you like it or not, don't look at the IMS graphs which these pharmaceutical people keep looking. They are anal about it. But patient considerations of oral, and we have some experience with oral. I think everybody in the audience used oral semaglutide. It was a runaway hit. In fact, general practitioners use it more often. In fact, people took it off label also because it caused weight loss. It was a little difficult to take because it has to be taken at 3 milligram, 7 milligram, 14 milligram. Now 25 and 50 will come in. But oral semaglutide clearly was indicated for diabetes. It didn't have an approval indication for weight loss, but 25 and 50 will have the weight loss indication. For the US FDA, the approval came as an adjuvant to diet exercise for glycemic control for adults. And it also has an added indication in the US for the 3-point MACE, which is cardiovascular death, non-fatal MI, non-fatal stroke in people who are adults with type 2 diabetes and established cardiovascular risk. As I told you, you have to take it on empty stomach on waking up. Take it with a sip of mouthful of water. Wait for at least 30 minutes and then take any other oral medication very clearly. So that's something which we recognize very clearly, and we know that we start with 3 milligram for 1 month, 7 milligram, and then we go to 14 milligram. And very clearly we got good data. Extraordinary science, both from RCT and real world evidence. I think we have to give credit to the innovator. They have done some extraordinary science around it. So let's be very transparent about it, that they have done some extraordinary science. You all have done extraordinary science in terms of the peptide biology and the manufacture and the purity of it. So robust A1C reduction and weight reduction is seen with orals. So we have proven results across the entire Pioneer program. Many of you all in the audience may be part of Pioneer. I know Sanjay Reddy is a big clinical trialist with Dr. Prasanna Kumar and his team, Dr. Srinivas Murthy, Bansi, Manoj, many of them do a lot of clinical trials. And I think that's very clearly recognizable that the drop of A1C with oral semaglutide 1.5% is a very potent drug. And clearly we recognize that pathway. So if you see that entire spectrum of various trials and weight reduction also very, very robust. So clearly that data space is there. So up to 2.6% is seen in the real world. And that's the truth. I saw a larger A1C drop in real world when I used semaglutide. And I have used it for last 3 years, and I'm sure everybody here has used it. And even for weight loss, because we are thin fat Indians, we saw larger weight loss in real world evidence. So there is a big gap between RCT and real world. And that is very visible and palpable because we all have to use it. So remember, whatever you see as data presented, when you use it in practice, this agent actually works better. And the CV benefit is proven beyond reasonable doubt because Seoul, and India was a large center for Seoul. In fact, the lead center, Dr. Rajpur, actually took over from Dr. Mittal and clearly recognizes that 14 milligram of oral semaglutide reduced A1C, reduced body weight, reduced albuminuria, and remission of albuminuria was seen, improved lipid profile, reduced inflammation with HSCRP, reduced blood pressure, and had a statistically significant reduction of 14% of the MACE. So basically it was as good as a statin. And clear data. So Seoul clearly stamped oral semaglutide. So who are the people who will benefit from it? What are the patient profiles who will benefit from oral semaglutide? Male, 36, works as an accountant, recently diagnosed with type 2 diabetes, started on metformin since 3 months, wants better sugar control. So look at the A1C, 8%, fasting 140, BMI around 25, weight 78, blood pressure, lipid profile abnormal, recent diagnosis, non-smoker, no other disease. Wants to have better glucose control. Think of an oral. And if he's metformin intolerant, semaglutide can be just the agent of choice. So even at diagnosis, you can start oral semaglutide, even for diabetes. So that's the first case illustration which we want to do. Let's look at another case. You have an overweight patient, not controlled well with 1 or 2 agents, like a sulfonylurea or a gliptin, which we typically use. This is Kirti, 37-year-old female, working in Cyberbath with IT professional. She goes to see Dr. Rakesh Sahai, married with 1 child, diagnosed with type 2 diabetes for 1 year, concerned about gaining weight because that's a challenge, That's the age, 37, they start getting depressed about weight, they go a little crazy, and then you want to have a better glucose control with additional weight loss. And again, in such an individual like Kirti, think of starting clearly a oral semaglutide. Let's move to another person. Systems engineer, 35, in Bengaluru. Okay. Again, now the buzzword is SGLT2. Because a lot of our patients already coming in our clinic are already on SGLT2, but overweight with severe risk factors. Apprehensive because this particular individual at an A1C of 8.2, 80 kilograms of weight, has a very, very strong family history. And deaths, cardiovascular deaths, at premature ages of heart attacks or strokes. Please think in such an individual. You will get much more compelling data and outcomes if you use an oral semaglutide. So clearly I gave you 3 case illustrations of hit hard, hit early as first line or a second or a third line or person who is likely to die with a fear of a strong family history. So the oral semaglutide is a first oral GLP-1 convenient option in early type 2 diabetes. Well established efficacy and safety. It's a good option for treatment initiation as a first add-on therapy. Can be easily added as an add-on with a metformin or SGLT2 without any dose modification. And has CV benefits with a statistically significant reduction in MACE and very clearly will lower weight and waste both, lipids and inflammation both, and a better CV trajectory. Once you will think, why is Shashank talking of oral even today? Okay, I'm sure I can sense Bansi, I feel him, he's like my younger brother, and very clearly he'll say कि Shashank को पागल हो गया, आज उसको डायरिया हो गया, so something is wrong with him, But there is a role. I gave you 3 case illustrations, and in diabetes there is a role. And I'm sure Dr. Reddy's lab may be having some agenda here because I'm sure they will come out and they will bypass, they will have their own snack. Snack is under patent. Semaglutide is getting off patent. I think what is the date? Magic date? March 21st, right? Become a very popular 22nd, right? Arjun, what is the date? 21st of March, Some special Muhurat, it's like, yes, So clearly there is a role, Bansi, in the diabetes space. Let's look at injectable semaglutide in type 2 diabetes. So clearly there is a role for injectable semaglutide that also has approvals. Both US FDA and Indian approval for diabetes and MACE, and clearly also for kidney. I am told Dr. Reddy has a nephrology division and they are going to have a new name in the nephrology space also. Correct me if I am wrong. Correct, Arjun? Okay. And clearly we know that once a week, which can be given any time with or without meals, start with 0.25, then after 4 weeks go to 0.5, then after 4 weeks go to 1, and then you can even go to 2 milligram. Again, 2 milligram is an advantage they have. If you miss a dose within 5 days, otherwise skip it. You can give it in the abdomen, give it in the thigh, give it in the upper arm, and rotate it wisely. If you want good weight loss, do not inject it in the abdomen. Always inject it in the thigh. Okay, this is my practical pearl on it. I am sure Bansi will agree with me, because if you inject it in the abdomen, you don't get that impact. And you will create holes and scars in the abdomen, and particularly women who have exposure of abdomen have a challenge. So remember that thigh administration is the preferred route for the Indian population. And we have some data, very interesting data. I am going to include Bansi as also author on that publication, that for Indians, the thigh or the upper arm rotation works far better than the abdomen. And you can see to believe it. If you are using the agent, you will recognize it, particularly in the semaglutide world. And the robust data, which we know, once a week or 1 milligram, sustained superior reduction across the entire program. You can see here very, very clearly. Monotherapy versus agents versus GLP-1, the entire program which Novo has done is an extraordinary drop of A1C. Again, when it comes to CV safety, very, very clear data that there is a reduction of MACE in high-risk patients and a very early separation of curves. In fact, if you see the composite outcome, even for kidney study, which is the flow study, because everybody has seen the CV study, 24% reduction in the composite outcome of kidney disease progression, CV death and kidney death. The CKD type 2 diabetes, clearly you can see that the flow data is so compelling. And therefore we clearly recognize this. So if someone has proven CV, CKD and peripheral artery disease, the injectable semaglutide has very high efficacy and it's standard of care. So let us look at patient profiles, because ultimately we are treating patients. We are all daily wage earners. Courtesy Bansi and Reddy Labs, I have to sacrifice my daily wages. I'm sure he has done that for the last couple of days. I can see Amit smiling. Okay. Female, 42, works as a bank officer, based in Baroda. Okay. Has a customer facing role. Diagnosed with type 2 diabetes, 5 years. Motivated, but cannot control glucose or weight because he's customer facing. All the time he's giving sugar tea to everybody, some gathiyas, some food, because he's trying to induce patients. So he's also eating simultaneously, and he has lost confidence. He thinks he can't control his sugars and weight. Sahib, mane nahi bhavto, I can't manage it at all. It's a problem, and we see these people every day. I'm sure across India you will have such bank officers who are very hospitable, and he just lost his self-esteem. He doesn't have confidence on weight issues, cannot control weight, and his confidence is gone. What is the A1C? 8. Sugars are okay, 72 kilograms of weight, blood pressure is high, total cholesterol is 320, and 5 years, non-smoker, no other disease, on metformin and DAPA with diet and exercise. Family history, father had a heart attack at the age of 40. And with such a low self-esteem and confidence due to weight issues, if you give him an injection once a week, you will change his life. Trust me here. Sorry. Okay. I have to check my eyes. 48-year-old man, businessman, okay, type 2 diabetes since 10 years, busy lifestyle, wants glucose control, weight control and CV protection, A1C 8.3, fasting sugar 182. Again, in this particular individual, you can see very clearly 3 OADs, very common in our practice: atherosclerotic cardiovascular disease, uncontrolled diabetes. Offer them an injection. Another person, again business person, because these are the people who will afford all this. Not control on 3 agents with CKD. And that's the big game changer. The advantage of semaglutide with the flow data is so compelling in the nephro space that nephrologists, just like the way they have embraced SGLT2 inhibitors, will embrace semaglutide. And therefore, in this case also, you think of it. So, injectable semaglutide in type 2 diabetes clearly will cause weight loss with uncontrolled oral agents. If you start slow, go slow, you will have good tolerability. Very high efficacy for glucose and body weight reduction as a first line. Recommended first line with proven cardiovascular benefits and the only GLP-1 agent with proven kidney benefits. I'm not talking of liver here at all. That's another indication. You have osteoarthritis of the knee, we have sleep apnea, but I'm not getting there at all. Let's move gears to obesity. Because obesity clearly has also approvals. If your BMI is above 30, without any comorbidities, or if your BMI is 27 with any comorbidity, very clearly there is a consideration. Can I use it in adolescents and pediatrics? Well, Indian DCGI above 18 allows it, but globally about 12 has been used. BMI above 95th percentile can be used. When not to think of it? Well, if you have other products or other GLP-1 agents, if you have allergies, if you have gallstones, if you have history of acute or chronic pancreatitis, you need to avoid these agents. Again, you can start with 0.25, 0.5, 1, 1.7 and 2.4. If you miss a dose, there's a missed dose protocol. What is the data in overweight and obesity? Clear separation of curves of outcomes you can see compared to placebo of 14.9%. So in adults with overweight or obesity, once a week semaglutide clearly will have an intervention for sustained clinically meaningful weight loss with 80% or 85% achieving more than 5% weight loss and 1 out of 3 achieving more than 20% weight loss. This is very compelling. And we are thin fat Indians. So though tirzepatide may appear to have better weight loss compared to semaglutide, in our population which is thin fat, I would not worry too much because we have used both the agents, oral injectable, and we have got a good amount of weight loss. The challenge is that there is long-term weight loss sustenance. They work long-term, and we have now data in the liver space because we have this whole term, the non-alcoholic fatty liver disease has been recoined as the metabolic associated fatty liver disease and MASH, and the ESSENCE trial clearly is going to define the documentation of that to reduce the indication. And clearly we see the biggest game changer of injectable semaglutide is the first anti-obesity medication. First anti-obesity medication with proven MACE reduction with overweight and obesity in CVD even without diabetes. That 20% early separation of curve at 20 days. There is something pleiotropic about semaglutide as a molecule because we have so many other GLP-1 receptor agents. But the early separation of curve is weight independent. And that is something which we all have seen. So clearly what are the key patient profiles? Well, if somebody has obesity without comorbidities, a 22-year-old male student, unhealthy eating habits, cannot lose weight, wants to lose weight using medications like his friends. This is the commonest class of people walking up to me, college-going kids. They really are of marriageable age. They have real challenges, and we are seeing these people who are walking in every day. I'm sure you all have also seen this. You need to, of course, filter them correctly, drive them through science, and use it appropriately. Second group, which we see, female, professional IT, hectic lifestyle, desk job, BMI more than 27 with prediabetes. wants to lose weight, get rid of physical restriction, daytime sleepiness and lethargy. Clearly, that's another recognized feature which we see. Another professional with type 2 diabetes since almost 10 years, sedentary lifestyle, but has MASH or MAFLD. Not an alcoholic at all. Again, worried about a liver condition. Another indication for injectable semaglutide. So clearly we see that 2.5 milligram or 4 milligram of semaglutide clearly has a role with a high efficacy and clinically relevant weight loss. But a lot of the weight loss is driven by fat loss. Because people have concerns about a muscle to fat ratio. And there is a sema-lean study. For brevity of time, I'm not showing that here. We wrote a correspondence, me and Shambho, to that also, to the authors, that we are thin fat Indians, but there is a preservation of the lean body mass. And even inside the muscle, what is seen as fat loss, there is actually myosteatosis. There is fatty kidney, fatty liver, fatty pancreas, fatty muscle. So even the fat inside the muscle goes out. And therefore that so-called muscle mass reduction which is observed by various methods of body composition measurement is actually the fat loss. Because they have stronger muscles after semaglutide. And there is a proven MACE reduction and also statistically significant reduction in MASH and liver fibrosis F2 to F3. Now for all weight loss, before I go to the final slides, we must focus on these couple of points. Emphasize on having adequate protein. We are a protein deficient country. Not because Dr. Reddy's Labs has a sister arm making proteins, but we are a protein deficient country and we need to give proteins, particularly in this environment, and hydrate the patient. Because if you don't hydrate and don't give proteins, you will not get success with this agent. Second is focus on muscle mass and function and preservation, which is not a function of protein or hydration. It is a function of resistance exercises. Many people walk up to me and say, I have taken, the semaglutide 1 milligram, I'm not losing weight. I said, are you exercising? No. Start going, join a gym, do utak baitak, do Surya Namaskar, and they lose weight. If you do resistant exercises and preserve the muscle mass, you will get better weight loss and lesser side effects. Because remember, the very fact that when you build muscle, it becomes a satiating effects. Always look at mental health. Because obese population particularly has mental health issues. And therefore connecting with them and improving their negative mental health status to a positive health outcome status is clearly there. And these drugs will have anti-addiction potential. People are giving up their food cravings, their alcohol cravings, and I wish that they can give up smoking cravings also, and then my friend Arvind won't smoke at all. I'm sure he will still, independent of all this. Okay, but I think he's given up to a great extent. Okay, so clearly we need to recognize that mental health issues are important. So whenever you are encountering a person you want to give this agent, please have a dialogue. And if you have a red flag for suicide, refer them to a professional psychiatrist. That's really very clearly there. It's not in the footprints because these companies are so much bothered about marketing the product that they don't tell us all these things. The other thing is musculoskeletal health. Skeletal is as important. Bone health is as important. There is no point in giving this agent to an elderly individual who's frail, who has a T score or a Z score of -3 or -4. Not because again Dr. Reddy Labs make Prolia and other agents. They have the entire spectrum from the Amgen stable, but bone health preservation is equally important in success of your therapy. I have been running a weight loss clinic for almost 30 years now. Finally, oncovigilance. Remember, people living with obesity have a propensity to develop various malignancies. And therefore, screening them for these malignancies prior to administration of the drug is something which you should do. Because sometimes what may happen is you may start them on the drug, they will lose weight, and suddenly they will be diagnosed with the malignancy and they'll attribute it to you and the drug. So it's a very important clinical tip that before you start these agents, screen them for mental health, bone health, you will get a body composition and muscle strength also. Look at the dietary protein and hydration and oncovigilance. And ultimately look at health outcomes. Health outcomes come last. That's why I put the double 5 there. Okay. The protein, muscle mass, mental health, bone and oncovigilance is equally important in screening whenever you're considering these agents. So clearly, I think affordable, accessible, available GLP-1 based therapies are going to be available, and we have to congratulate DRL and various other Indian companies for allowing us to talk in these symposiums to educate all of us. I think that affordability will clearly improve quality of care, make larger population accessible to this. I am sure what you listen to me today, you will learn and you will adapt it into your day-to-day care. And once again, I'm grateful to Reddy Labs for giving me an opportunity to speak to all of you. Thank you so much.